Hello, I'm Keith Fox, and here we are at the end of another exciting day at the ESC Congress. And I'm delighted to be with two chairpersons of the hotline sessions today, Sarah Clark and Frans van der Werf. And we're going to start, Sarah, with spiral hypertension. So is renal artery ablation dead or not?
I would say it's not dead. I think there's opportunities here. The current study of spiral hypertension off medication was designed on the back of the previous Simplicity studies, which actually, in retrospect, didn't actually weren't well designed. There was a problem in that there was quite a lot of variation in medications that the patient took. There was incomplete denervation delivered, and patients were included who had isolated systolic hypertension. In addition, some of the operators were inexperienced, so they've learnt a lot from Simplicity 3, and this was used to actually, the later study was actually used to try and confirm that it does work in uncontrolled hypertension, so people off medication.
Off medication. So this avoids the problem that there were non-responders due to people who weren't taking the therapy.
Plus people changing the medication.
And changing medication.
Yeah.
But the blood pressure decline was rather small. It less than could be obtained with medication.
It was about 7.7 for systolic and about 5 for diastolic at the 3-month mark.
Yeah.
So, but you know, 7/5 change is an appreciable delta.
Yes.
And if that's sustained, then that's worthwhile. So here's an important step that says that renal denervation may be on the revival.
Yes. And it may be that it's an add-on. It may be that patients take medication, or they have renal denervation and then they need medication to bring them down to target of 140.
Okay.
There was a discussion about it being a cure, but I think that's unlikely to be a viable option.
So let's continue with the theme of high blood pressure with precision ABPM. Frans, what are the key findings from this study?
Well, you know, the precision is a large trial that has been published. The key outcomes, more than 20,000 patients published in New England last year. But here, a sub-study in about 200 patients was presented, looking at the effect on blood pressure of the 3 anti-inflammatory agents, selective...
Non-steroidal anti-inflammatories.
Yes. So, celecoxib and well-known ibuprofen and naproxen.
Yes.
Conclusion, there was a significantly greater increase in blood pressure with ibuprofen than with celecoxib. In between was naproxen. In fact, there was no increase in blood pressure with this selective COXIP inhibitor, but the increase in blood pressure with ibuprofen was significant and sustained during 4 months.
So a serious take-home message: be wary particularly of the non-steroidals, and in particular ibuprofen and its impact on blood pressure.
Yes. But a major criticism of this study was that there was a limit of the dose. There was a maximum dose of 200 milligrams for celecoxib, and much higher doses when you look at the anti-inflammatory effect of these other 2 agents. So they were not equipotent.
But they may not be balanced for their anti-inflammatory activity.
But certainly one has to be careful with these agents, and especially with ibuprofen.
Okay. So, Sarah, Impact AF, in a nutshell, what's this about and what did it show?
So we know that atrial ablation causes a 5-fold increase of stroke, and that 2/3 can be prevented with anticoagulation. So this was a study that was in more third world countries, so Brazil, India, well, Japan, no, it's not Japan, India, and what it was doing was looking at educating patients. A series of follow-up calls, seeing them and providing them with educational materials to make sure they stayed on their anticoagulation. And at the end of the first year, those that weren't on anticoagulation at the beginning, 48% of them were on it at the end of the first year. So there was a significant compliance improvement seen with the trial.
So this is a big change, because
a big change.
You know, there have been other programs that have been disappointing in their educational impact, this has worked.
It has
and
worked.
it's worked in diverse parts of the world.
Yes.
But mostly developing
countries.
Huh?
Yes. Well, I wouldn't call
good.
Argentina a developing country.
No, I agree, but well, it's not perhaps the level of Western medicine. But,
I mean, we have challenges in all our countries.
Yeah.
Okay, so let's move on to the controversy around intubation versus mask ventilation after cardiac arrest. So Franz, what do you think about that?
Keith, this was an important study, I believe. The background was that a huge registry in Japan has shown that back mask ventilation may be better than intubation in patients with out-of-hospital cardiac arrest. Now, about 20 SAMU centers from Belgium, most from France and a few from Belgium, did a randomized study comparing intubation with this back ventilation. And surprisingly, there was absolutely no evidence that the mask back ventilation was superior to intubation. In fact, on the contrary, there were more complications with this back ventilation, probably also because insufficient ventilation, regurgitation of gastric fluid, etc. So I believe an important study.
So key message is that a randomized trial can resolve this, whereas the registry data may be confounded, and we need to follow the data from the randomized trial.
Absolutely.
Okay, so thinking about oxygen, Sarah, detox.
Detox 2, isn't it? I quite like the name of the title, it's a good one. So this is looking at oxygen therapy in the STEMI patients. We know that when patients arrive in the emergency department, the oxygen mask goes on straight away, and it was looking at those with an oxygen saturation of more than 90% to see whether it made any difference. And interestingly, it made no difference to mortality or troponin. So there's a question as to whether patients actually need this oxygen that's being given to them all the time.
So this is very interesting because, you know, we know all our patients with ST elevation MI, some are hypoxic, but the majority are not. So my challenge is, perhaps there are going to be some potentially hypoxic people deprived of oxygen.
But if the saturations are above 90%, then maybe they don't, well, the study suggests they don't need to have oxygen, but those below should have it.
Yes.
It's a standard measurement now when a patient comes to...
and in the new
so the simple thing is, so long as they're over 90, they're okay.
Yeah.
And the elegant thing about this study is, again, from the Sweetheart, the Swedish group, very beautifully done, large-scale study, much bigger than the others, and registry-based randomization.
And no patient lost to follow up.
No patient lost to follow up.
0 patients lost to follow up. So let's move on to Sildenafil.
Yeah. There was a Spanish study in patients who had valvular surgery, corrected valvular disease, stable, but with pulmonary hypertension. And they were randomized double-blind with a high dose of sildenafil versus placebo. And they pre-specified 3 categories: patients who improved, patients that did not improve, and patients that remain unchanged based on a number of endpoints, including subjective findings of dyspnea or not. And surprisingly, the overall picture was that it was negative for sildenafil, and the conclusion was that this should not be given routinely to patients with pulmonary hypertension after valvular surgery. Explanation
but with the caution that this is quite a heterogeneous group.
Correct, Keith. Some patients improved, others did not. And so probably the reason is that some patients had a different type of pulmonary hypertension, pre-capillary versus post-capillary hypertension. And that might explain the discordant findings of this study. But overall, the picture was negative.
So we've seen a lot of presentations of monoclonal antibodies that are inhibiting PCSK9, but there is a radical different approach, which is using interference RNA to inhibit the synthesis of PCSK9. What are your thoughts, Sarah?
A sort of disruptive therapy, isn't it, really, trying to prevent the PCSK9 influences across the board by actually going into the RNA at the RNA level. I think this is an interesting study because they looked at various dosing, but they found that once they got the dose built up, actually you could keep the LDL down by 50% with 6 monthly injections. So that actually changes the game altogether. Some people may prefer taking medication, but others may just prefer a trip every so often to have their injection done at the GP every 6 months. I don't think it means it doesn't replace statins. This would probably be an addition.
Yeah, so key message, it doesn't replace statins, but for particularly high-risk people, like, for example, the heterozygous FHs and many of those that are resistant to conventional full-dose statins, there's potentially an important place.
It's a very promising study.
Will it be a competitor for the monoclonal antibodies?
Yes, I think it is.
Yeah.
Yeah.
Although the mechanism is totally different.
Yeah, but you know, interestingly, we're going to talk about natural randomization and natural randomization, genetic randomization in relation to PCSK9 revealed exactly what we would anticipate from the PCSK9 studies. So let's finish with a little insight into that.
This was a very difficult study, had some difficulties to understand it all. So they looked at a huge population of more than 100 participants, and they looked at genetic variants encoding for the target of CETP inhibition and the target for statins.
Yeah. And it's based on the assumption that there is a natural distribution and using that natural distribution of the variation in those.
Correct, and they validated it also in studies. And so it was of interest. My conclusion is that we all know that if, in spite of the fact that there is an LDL reduction with these CETP inhibitors, there is a disappointing effect on cardiovascular outcome. And so they conclude that this is probably due to the fact that there is a discordance between what you measure as LDL cholesterol in these studies versus ApoB. And that if you look at studies in which both are given together, a statin with a CETP inhibitor, you have to look at ApoB and to correlate that with a possible outcome in favor or.
And this may be a really important issue in relation to other studies that are taking different approaches to lipid modification.
Absolutely. And tomorrow morning in the next hotline session, there will be another big study, the REVEAL study.
We'll see what it says.
Yeah.
So thank you both. Thank you to Sarah Clark. Thank you to Frans van der Werf. We've had some important insights. And what we've learned today is it's not enough just to use observational data. The randomized trials have given us important new insights that are going to change practice. Thank you.
Thank you.
Thank you.